Hi, my name is Devang Patel and we are discussing about temporomandibular disorder in this series of videos on occlusion. In this video, we will discuss about diagnosing some of the commonest temporomandibular joint disorders which you may find in general dental practice. So let's look at the classification of temporomandibular joint disorder. This classification is derived originally from Weldon Bell, however, which is modified from Dr. Jeffrey Oxon. It's been taken from Dr. Jeffrey Oxon's book, Temporomandibular Joint Disorder and Occlusion, 8th edition. I would highly recommend whoever would like to improve their knowledge on temporomandibular joint disorder to read this book or follow Dr. Oxon. He is brilliant. So let's look at the classification. In the classification, the first one is masticatory muscle disorders. In that you have protective co-contraction, local myalgia, myofascial pain, myospasm, and sensory-mediated myalgia. The second category is temporomandibular joint disorders. In that you have derangement of the condyle disc disorders. In that you have disc displacement with intermediate locking, or disc displacement without reduction. Now, reduction is a terminology derived from orthopedic surgery aspects where they are reducing the bone or they are reducing the fracture, which means they're putting things together. So when you have disc displacement with reduction, which means disc is displaced but comes back to its normal original place. When it's without reduction, that means it doesn't come back. We will discuss about that more in detail in later this video. The second category is structural incompatibility of the articular surfaces, in which you have deviation in form by disc, condyle, or fossa. You have adhesion, which could be disc to condyle or condyle to fossa. So you have a disc which has a space between the condyle and the fossa, and sometimes you have a disc adhesion with the condyle or the disc adhesion with the fossa. And when that happens, what happens is sometimes if the pressure is increased in temporomandibular joint, the fluid which is separating the disc between the condyle and fossa can disappear, and that can lead to adhesion. Usually that happens in the morning, and when patient opens, they can find jaw clicking in the morning, and then it's fine throughout the day. It doesn't click. So they're loading their jaw joint in the night time, and that causes to temporary adhesion, but it can lead to more chronic issues. Then you have subluxation, hypermobility. We've all seen patients such as those, or luxation, where patients open their mouth and now cannot close that jaw back together. The other category is inflammatory disorder of the temporomandibular joint, which includes capsule inflammation, retrodiscal tissue inflammation, some of the arthritis related issues, or inflammatory disorders of associated structures such as temporal tendonitis or stylomandibular ligament inflammation. So it's more inflammatory reaction to the joint. The third category is chronic mandibular hypermobility, and in that you have ankylosis, either it's a fibrous or a bony ankylosis. You have muscle contracture, which could be myostatic or myofibrotic. You have coronoid impedance in this category. And then lastly, we have growth disorders, which could be congenital growth disorder of the muscle related or temporomandibular joint related, which is a bone related. If it's a bone related, you can classify in that agenesis, hypoplasia, hyperplasia, or neoplasia. In muscle related disorders, you can see hypertrophy, hypotrophy, or neoplasia. So these are some of the temporomandibular joint disorders you can find in patients. As you can see, it is a very complex subject, and it is impossible to cover everything in this video series. And because of that, I've selected some of the most commonest disorders you find in your general dental practice, which you may be able to treat in general dental settings. However, you need to realize that in order to treat temporomandibular joint disorder patients on a regular basis, you need to be able to assess and diagnose and pinpoint each and individual diseases, and which needs a specialized training and mentoring. So if you are interested in that, please pursue the subject further. However, in this series of videos, I'm concentrating on things we can do as a general dental practitioners to treat some of the commonest diseases. However, even if you're in a general dental setting, you should be able to diagnose the temporomandibular joint disorders, because these are the cases you shouldn't do any complex treatments, or you shouldn't do any treatment until the pain has been rectified. Even once the pain's been rectified, you need to refrain from doing more complex treatment and try and find a simplified way to treat that patient, because there is always an issue with adaptability of patient's joint, and you may not want to stretch that adaptability because you don't have a clue as to how adaptable that joint is. If you want to do complex treatment, then take one step at a time, and that will help you in treating patient more harmoniously without giving patient any pain. So this in mind, let's start with looking at some of the masticating muscle disorders. So the first masticating muscle disorder, which is very common, is called protective co-contraction. Now, co-contraction or protective co-contraction is a very common phenomena which happens in even normal patients or normal person. This is basically a co-contraction when, let's say, your jaw is closing, your depressor muscles are slightly in active mode, because to avoid, let's say, if you have stone between your teeth, it needs active so that it can straight away open the mouth quite quickly to avoid further damage. And that happens with all the jaw joints in the body. And however, if this becomes exaggerated because of some of the etiologies, then you can get protective co-contraction, which is a little bit of a discomfort or a pain. So what are the etiologies related to this disease? So one of them is altered sensory or proprioceptive input, constant deep pain input, or increased emotional state. Now, this is usually if you have if you give a patient a high restoration and patient's adaptive capability is not good enough to adapt to that, then patient may develop the protective co-contraction. So what basically jaw is trying not to close completely in order to protect that jaw teeth from pain. And because of that, the opposite of closing, which is opening muscles, are constantly in tonus position and they get tired. And because of that, patient cannot open very wide without inflicting pain. Constant deep pain input, which could be dry socket, which is now resolved, which has been there for some time, resolved, or is there and is resolving, patient can develop this kind of protective co-contraction. So what is the history of patients having this disease? So patient will generally be able to pinpoint when this started, because it's usually a day or two old. Patient will be able to tell you, oh, it wasn't painful last week and now it started paining. So you should be able to try and pinpoint or locate where is the etiology. It's a recent source of constant pain, deep pain, or patient may describe as a recent increase in emotional stress. So they're going through some emotional stress, and that could cause this kind of issue. So in regards to clinical characteristics, you see some structural dysfunction which is associated with decreased velocity and range of mandibular movement. Any restriction, though, is secondary to pain. So because the patient's in pain with the tooth, they may not be able to move around that side of the jaw. However, if you ask patient to slowly and carefully open their mouth, they should be able to open their mouth properly. Usually there is no pain at rest, and there is increased pain with function. So although pain will minimize jaw function, still patient can manage full range of movement if they want to. So there is no restriction per se, but it's just a secondary to the pain. And patients have the feeling of muscle weakness. There is no actual muscle weakness, but they feel that the muscles are weak. So if, let's say, you let the restoration high enough for long enough, then patient can go into local myalgia, and that is continuation of protective muscle co-contraction, or continued deep pain, or trauma. So you've seen this in your career probably, that you've given patient a mandibular jaw block or a nerve block, and patient then develops a trismus, and now even though the numbness is gone, the trauma is gone per se, patients still cannot open their mouth for months, and that is related to progression of the muscle damage, then local myalgia developing, and then sometime it becomes CNS related muscle pain. Or patients using chewing gum or something unaccustomed use of things or a habit can cause this issue as well. Increased emotional stress again can cause local myalgia. In history, you find that the patient began several days or hours following the event associated protective co-contraction. So it's not really immediate. It takes time. Again, it's a secondary to deep pain input. So there is a deep pain input coming from somewhere, but it's been there for some time, and then local myalgia develops. The pain began associated with tissue injury. It could be injection, opening wide, or unaccustomed muscle use from bruxism. Or again, recent episode of emotional stress. So how do patients present to you when they have this kind of issues? So usually there is a structural dysfunction. So there is a decreased velocity and range of mandibular movement because it's been there for a long time. However, still, any restrictions is secondary to pain. But importantly, slow and careful opening will not allow patient to nearly open their mouth as like a protective co-contraction. So because it's been there for some time, even if patient wants to open carefully wide, patient will not be able to open properly themselves. However, if you stretch the jaw by putting your fingers in the patient's mouth and try and stretching it, you may be able to stretch it up to a normal range of opening, and that is we call soft end feel, which we discussed in previous video. There is minimum pain at rest, and there is increased pain with function. When patient's functioning, there is more pain, and there is actual muscle weakness in this local myalgia cases. More importantly, when you palpate the muscle, you are finding that the muscle is tenderness. So you find some tenderness around the muscles when you're palpating. And this is the first time when the tenderness develops. Because in protective co-contraction, you usually don't have tenderness because it's pretty acute, it's quite recent. Now we have a CNS related muscle pain, which is myospasm. In this, you find that the local muscle condition like fatigue or changes in local electrolyte muscle balance can cause this. Some systemic conditions such as inherited factor of which is present, such as musculoskeletal disorder, can cause this kind of myospasm because it's CNS driven. Deep pain input, it may rise from local myalgia. So again, this is one step upward from local myalgia. If the pain continues for longer, CNS starts getting involved, and then you start getting myospasm. Or there is an idiopathic myospasm mechanism, which we don't know of why it happens. The patient usually in this case will report a sudden onset of pain, tightness, often a change in jaw position, and mandibular movement is very difficult to achieve in this kind of patients. So what are the characteristics? So if you look at the structural dysfunction, there is marked restriction between the jaw or mandibular movement determined by the muscles of mastication, and there is a spasm in the muscle. The structural dysfunction may also present as an acute malocclusion. Acute malocclusion is usually termed when there is a sudden muscle contraction, and because of that, there is a change in occlusion. And because of that, patient can all of a sudden start developing open bite on the opposite side because the muscles is contracting. And this is called acute malocclusion. Patient feels significant pain at rest, and this is the first time when you start seeing the pain, because in the first two disorders, patients were in pain, but not as much as myospasm. There is increased pain with function, there is definitely local muscle tenderness, and patient feels muscle tightness. So these are the three main muscle disorders. Now, if you see, if this progress onto, then you can get centrally mediated myalgia, where patients having muscle pain, which is mediated by CNS. Now, in these cases, when you are asking patient to treat, is slightly different than, say, let's say protective co-contraction. We will go through more in detail in next video. However, protective co-contraction, you really don't need any treatment apart from removing the etiology, because that's the reason why patients in pain. So let's look at some of the temporomandibular joint disorder which you may see in your general dental practice. So one of the most common disorders you will see is derangement of condyle disc disorders. And main etiology of this is either macrotrauma, is trauma, it could be macrotrauma or microtrauma. Macrotrauma we all can recognize, patient can spot, and patient can tell you, okay, I had an accident on this day, and because of that, I'm in pain, and since then, everything's joys, mood, change of occlusion and everything. However, macrotrauma is something patient won't be able to tell you because it's happening repeatedly. That is something to do with bruxism, continuous use of muscle, which is causing hypoxia, and reperfusion injuries, and orthopedic instability can also cause this microtrauma. So if you look at the discs, as we saw in the first functional versus dysfunction video, that you see the condyle disc assembly, which is most superior anterior position, and disc is covering the condyle, whereas if there is a disc displacement, you can see that the thinning of the posterior border of the disc, and because of that, the disc is slipping forward, and that's causes the displacement of the disc. So let's look at the first disc displacement disorder, which is disc displacement with reduction. Now, when you see history, patient will pinpoint that there is a trauma, again, if there is acute trauma. However, microtrauma is difficult to assess. Patient may not be aware of that. In these cases, pain may or may not be present, but if it is almost always intracapsular and associated with dysfunction, which is the click. So patient usually clicking and getting pain together. So what are the clinical characteristics? So usually when patient has disc displacement with reduction, which means the disc is going forward but coming back into its normal position, so it's reduced, then you see joint sounds occurring, opening and closing duration, or just opening sometime. However, there is no restriction in jaw movements. There is a normal range of jaw movement, both opening and closing. And this is a very important feature. There is a limitation only due to pain, not due to structural dysfunction. So if patients in pain, they're trying to reduce the pain, and that's why they're not opening or closing properly. But usually they should be able to open, close normally in this, if there is a disorder such as disc displacement with reduction. So when there is a reciprocal click present, which is when patients opening and closing, it usually occurs in different degree of time. So let's say patients opening and the first click is at 30 millimeter opening. The second click could be at closing maybe when closing very close to 10 or 8 millimeter, very close to the intercuspal position, and that's when capsule slips back. Whereas if you have a disorder such as some of the deformation of the mandible, you see the opening and clicking at the same time. So if there is an opening at 30 millimeter, the closing click will be at 30 millimeter as well. So if they are both at the same time, then you need to consider maybe some deformation of the jaw, condylar deformation. However, usually if there is a disc displacement with reduction, the opening click could be any time, but the closing click is usually when patient's just about to close intercuspal position. So this is the disc displacement with reduction. Let's look at the disc displacement without reduction. And you see in this case where the disc now is completely in front of the condyle. So there is no way the disc can slip back, because even the posterior border of the disc is in front of the condyle, and it's very difficult for disc to slip back. Now that means it's not reducing back into normal position. So the most of the patient knows usually when this happens. So they usually can open their mouth properly. It starts usually with the clicking, and then one day they can't open completely. And they can really relate to the event, such as if they may be biting something hard, piece of meat or something like that. Usually, as I said, there is a history of clicking before the disc displacement without reduction. And when that happens, that is sometimes a warning sign when it keeps happening. But again, we'll discuss about the treatment in next video. In this case, typically patient can open within 25 to 30 millimeter of the range. And remember, that range is purely rotation movement when disc is not playing much part in it. So when mandible is rotating, disc is not playing any part. And when it needs to slide, disc is not letting the mandible slide forward because it's in a way. If you try and open wider, the mandible deflects to the affected side. So involved joint. So if the joint, the right hand side joint is involved, the mandible will move towards the right hand side when open. You definitely feel hard and feel. So you're trying to open the mouth, you feel that it's getting stuck like against a rock. So you won't be able to open it, unlike muscles disorder. And pain is not always present. So when it is present, it's associated with trying to open beyond the joint restriction. So if you're trying to pull beyond the restriction, it feels painful because the capsule is being crushed almost. So let's look at how the normal temporomandibular joint works, how it works when it's disc displacement reduction, and how it works with disc displacement with reduction acute, which is just happened, or chronic, which has been months or years. So if you look at the disc displacement, this is a normal joint where condyle is moving forward and backward, and disc assembly happily moves along with it. Now in the next set, where there is a disc displacement with reduction, you can see the clicking when there is a jump, and now the condyle moves back, and just about before closing there is another clicking when it closes. Now this is when it's not reducing, and now you can see that there is a limitation. So if condyle wants to translate, it's stopping. Now when it's chronic, it becomes fibrous, the joint, and patient may be able to move a bit further and open a bit wider. Some patient can open as normal opening because the joint has learned to relax and stretch the ligament, and ligament compensate for the capsule. And because of the fibrous tissue at the back, the pain is also eliminated. So these are some of the most common muscle and joint disorders you may find in general dental practice. In the next video, we will discuss about how to treat some of these most common temporomandibular joint disorder in general dental practice.